Let's talk about Leishmaniasis. You know, it's one of those diseases the WHO calls a neglected tropical disease, affecting millions in some of the poorest parts of the world. But here's the thing. In our hyper-connected world of global travel, military deployments, and migration, it's not some distant problem anymore. It's showing up right here in the Netherlands, and it's bringing with it some really complex diagnostic and therapeutic challenges that we absolutely have to get our heads around.
And that quote, it just nails the heart of the problem, doesn't it? A single insect bite, happening maybe thousands of miles away, can kick off this whole cascade of events that take some of our most advanced medical science to figure out, right here at home. It's a long shadow indeed.
Okay, so here's our game plan for this explainer. We're going to break it all down. We'll start with what the disease actually looks like, then dive into how we diagnose and treat it. We'll explore the long-term consequences, uncover a pretty big gap in our public health surveillance, and then we'll tie it all together with some real-world clinical cases.
All right, first things first, it is absolutely crucial to understand that Leishmaniasis isn't just one thing. It's really a whole spectrum of diseases, a constellation of syndromes, and each one has its own personality, its own pathology, and its own prognosis.
So you've got two main players we encounter. On one hand, you have cutaneous leishmaniasis, or CL. This is the one you see on the skin, these ulcers, and it's by far the most common. On the other hand, you have visceral leishmaniasis, or VL. This is the really severe form. It goes systemic, attacking the internal organs, and if you don't treat it, it's over 95% fatal. And as if that's not enough, there's a truly terrifying third possibility that can develop from some of the skin infections, mucocutaneous leishmaniasis, which just relentlessly destroys the tissues of the nose and throat.
So who's actually getting this in the Netherlands? Well, the data tells a really interesting story. There's a pretty sharp divide. Over half of the cases are military personnel. This is often tied to specific deployments, like the big outbreak we saw among Dutch troops in Afghanistan back in 2005. The other big slice of the pie? That's civilian travelers. Their infections tend to be more sporadic, reflecting individual trips all over the globe.
Okay, so that leads us right into diagnosis. Because in the modern era, managing this isn't just about spotting the parasite. No, it's about identifying it with pinpoint precision so we can map out exactly how we're going to treat it.
In any tissue sample, this is the bad guy we're hunting for, the amastogote. You can think of it as the parasite's stealth mode. It's this tiny, non-moving oval body that hides out inside our own immune cells. Finding one of these is the classic, old-school way of proving an infection.
And just look at how our diagnostic tools have evolved. Microscopy is fast, sure, but look at that. It misses almost 30% of cases. Culture is a bit better, but it can take up to a month to get a result. A whole month. And then you have PCR. With a staggering 98% sensitivity, it has been an absolute game changer.
But here's the real magic of PCR. It's not just that it's super sensitive. By amplifying the parasite's DNA, we can then go on to sequence it. And that lets us identify the exact species of Leishmania. That single piece of information right there is the absolute bedrock of modern, effective therapy.
Knowing the species is everything. And I mean everything. This knowledge allows us to ditch the old one-size-fits-all approach and move to a highly customized, species-directed therapy that's tailored to the specific bug we're fighting.
For cutaneous leishmaniasis, this is always the first question, the first major fork in the road for a clinician. Do we just treat the lesion on the skin locally, or do we need to bring out the big guns and treat the entire body with systemic drugs? The answer depends completely on the risk profile of that specific parasite.
So think of it like two completely different tracks. We've got simple CL, often caused by Old World species. If the lesions are small, few, and not on a critical spot like the face, you can often manage it with local therapy. But then you have complex CL. This is where you see New World species, with that risk of MCL we mentioned, or big lesions on the face. That demands systemic therapy, no question, to protect the patient down the line.
Now, when we do have to go systemic, our options are limited. And the only oral drug we have, miltefosine, while effective, comes with a massive warning sign.
It is a powerful teratogen, which means it can cause severe birth defects. It is absolutely contraindicated in pregnancy, and for women of childbearing age, it requires strict contraceptive measures for months even after the treatment is finished.
And this table really brings it all home. Look at this. If a soldier comes back from Afghanistan with a simple L major infection, they might just need some local therapy. But if a backpacker comes back from South America with L brasiliensis, it doesn't matter how small or innocent that skin lesion looks, it's mandatory systemic therapy every single time, because the risk of it spreading and causing that destructive facial disease is just too high to ignore.
And this is why getting the diagnosis and treatment right from the very beginning is so incredibly critical. Because the long-term consequences, the aftermath of this disease, can be absolutely devastating and last a lifetime.
For the skin form, CL, even a best-case scenario is a permanent and often disfiguring scar. MCL, as we've said, is just horrific, a relentless destruction of facial structures. Untreated VL is fatal, full stop. And then there's this really strange after effect of VL, called PKDL, where a patient who's been cured develops a rash full of parasites, turning them into a silent walking reservoir for the disease.
So we have this increasingly common, very complex imported disease. You'd think we'd be tracking it like a hawk on a national level, right? Well, this is where we run into a really big problem. And here we have this just stunning paradox. Leishmaniasis is not a notifiable disease in the Netherlands. That means doctors are not legally required to report cases to public health authorities. So on one hand, we have these world-class labs that can sequence the parasite's DNA, but on the other hand, we have no national system to actually track how many people are infected. The data we do have is just from a few specialist centers, which means it's almost certainly just the tip of the iceberg.
So what can you do? With no vaccine and no preventative pill you can take, it all comes down to personal protection. The only surefire way to prevent Leishmaniasis is to avoid getting bitten by that tiny sandfly in the first place. This makes good pre-travel counseling and people actually following the advice the single most important public health tool we have.
Okay, let's pull all these different threads together now. Because theory is one thing, but seeing how it all plays out in a real-world clinical case, well, that's where the most powerful lessons are learned.
So picture this. A patient, a 26-year-old, just came back from a jungle exercise in Belize. She comes into the clinic with a single small ulcer on her ear. It's about 2 centimeters, it doesn't hurt. I mean, on the surface, this looks like a textbook case of simple cutaneous leishmaniasis.
The dermatologist takes a biopsy, and, looking at the ear, the initial plan is for some simple local therapy. Seems logical, right? But then, the lab calls. The PCR result is back. It's Leishmania brasiliensis. And in that instant, everything changes. This is no longer a simple skin problem. This is now a high-risk infection. The treatment plan is immediately thrown out and escalated to aggressive systemic therapy, not just to heal the ulcer on her ear, but to prevent the parasite from, maybe years down the line, destroying her nose and throat.
In this case, just hammers home the central message of this entire explainer. You cannot judge the risk just by looking at the skin. Molecular species identification isn't just some fancy high-tech test. It is the non-negotiable, absolute standard of care. It can literally be the difference between a simple scar and a lifetime of disfigurement.
Which leaves us with a final and pretty critical question to chew on. As our world keeps getting smaller and the climate keeps getting warmer, the sandflies that carry these parasites may expand their territory. In that future, is our current approach, relying on a handful of experts without any mandatory national reporting, is that really enough to protect us? Is it enough to see what's coming over the horizon?